Step 1 respiratory case vignettes will often discuss lung physical exam findings. Here we'll try to identify the high-yield patterns that will help you clue into the diagnoses faster. Let's work through some scenarios together. If you hear decreased breath sounds at one or both lung bases, especially with dullness to percussion and decreased fremitus, you might think pleural effusion. Remember that fremitus is a palpable vibration you feel with a low-frequency vocalization. We'll talk more about pleural effusion later on. If you have a similar presentation, but with tracheal deviation towards the affected side, you might expect what condition? Bronchial obstruction, since you get the tracheal deviation as the lung collapses distal to the obstruction. We'll talk more about pneumothorax soon, but this is a situation where you have a collapsed lung. This is really the only condition where you expect to see hyperresonance. The collapsed lung causes a hollow space in the chest cavity. In a spontaneous pneumothorax like this, the trachea tends to deviate towards the side of the collapsed lung. With a tension pneumothorax, the tracheal deviation would be away from the side of the lesion because the trapped air on the side of the collapsed lung pushes the mediastinal structures, like the trachea, to the other side, as you see in this chest x-ray. Finally, if you have increased tactile fremitus, you should be suspicious of pneumonia or another consolidating process. Do you see the right middle lobe pneumonia in this x-ray? What would you expect to hear when you listen to the lungs? Late inspiratory crackles or bronchial breath sounds. Pleural effusions are generally classified as transidative or exudative depending on the underlying process that's causing them. Transidates have a low protein content, or a fluid to serum protein ratio of less than 0.5 and a fluid to serum LDH ratio of less than 0.6 when you examine the pleural fluid. Now, what's the physiologic mechanism for transidative pleural effusions? Well, they can happen when either the transcapillary pressure gradient is increased or the serum protein content and thus the oncotic pressure is decreased, such as in congestive heart failure, nephrotic syndrome, or hepatic cirrhosis. Exudates, on the other hand, have higher protein content, with a fluid to serum protein ratio of greater than 0.5 and a fluid to serum LDH ratio of greater than 0.6. Now, what drives exudative pulmonary effusions? Well, they occur as a result of processes that affect vascular or capillary permeability, such as malignancy, pneumonia, trauma, and collagen vascular disease. Exudative effusions typically need to be drained due to their increased risk of infection and empyema formation. One other type of exudative effusion worth mentioning is a lymphatic effusion, or a chylothorax. This is typically seen when the thoracic duct is damaged from trauma during cardiothoracic surgery or blocked by malignancy. When you tap the effusion, you typically get a milky white fluid that is high in triglycerides. As we discussed earlier, pneumothorax can present with classic absent breath sounds, hyperresonance, and decreased fremitus. Patients may also have some chest pain and shortness of breath. Usually these patients look very uncomfortable in the ER. Spontaneous pneumothorax typically occurs in tall, thin, young males who have these apical blebs that pop out who are otherwise healthy. So why does this happen? Well, no one's sure, but it's thought to be related to increased shear forces in the apex during respiration, causing accumulation of air in the pleural space. There are some causes of familial pneumothorax, especially with Marfan syndrome, Ehlers-Danlos syndrome, and homocystinuria. Another type includes traumatic or iatrogenic pneumothorax. You can probably guess what's going on here. The causes here include any trauma or injury to the chest, like from a car accident or a knife wound. Now, how can you, as the doctor or future doctor, also cause a pneumothorax? Well, it can happen when you try and place a central line, biopsy the lung, or put the patient on mechanical ventilation. As we mentioned earlier, tension pneumothorax is one of those few respiratory emergencies where you often have to treat it before the person gets to the emergency room, much less gets an x-ray. Now, this usually starts as a traumatic or iatrogenic pneumothorax where the air enters the pleural cavity but can't exit because of a one-way valve mechanism. When too much air gets trapped, it pushes the mediastinal structures, like the trachea, to the other side, as you can see here. These patients can be in severe respiratory distress that evolves to hypoxia, hypotension, and cardiovascular collapse in addition to absent breath sounds and hyperresonance. Now, if the patient's in severe distress or looks unstable, what would you do next? Well, you have to do a needle decompression immediately, even before you can confirm the diagnosis. So if they ask you on boards, reach for the needle first, then get the chest x-ray later. Flash quiz. On examination, what do bilateral dullness to percussion and decreased breath sounds bilaterally at the lung bases suggest? Pleural effusion. Anatomically, you can think of infectious pneumonia as lobar, bronchopneumonia, or interstitial pneumonia. Lobar pneumonia is characterized by an intraalveolar exudate that leads to consolidation, potentially of an entire lung. Do you recall the most common organisms in the outpatient setting from microbiology? Correct. Strep pneumo and occasionally Klebsiella. Here's an example of a lobar pneumonia in the right lung. Do you know what lobe it's in? Well, it's not in the right lower lobe because you can clearly see the right hemidiaphragm. So is it in the upper or middle lobe? Well, it's the right middle lobe. It's an example of that right middle lobe lobar pneumonia that you may remember from the anatomy part of the respiratory lecture. Bronchopneumonia is characterized by acute inflammatory infiltrates from the bronchioles that extend into adjacent alveoli. Now, typically you see patchy infiltrates on chest x-ray that involves more than one lobe. Here's a histology image showing neutrophilic infiltration into the alveolar spaces. Strep pneumo, Staph aureus, H. influenza, and Klebsiella are some of the typical bugs that can cause bronchopneumonia. Now, when do you expect to see staph pneumonia? You're typically going to find this as a complication of the flu or a viral pneumonia. You'll see it in IV drug users, hospitalized patients, old folks, and folks with chronic lung disease like COPD. Now, where do you find H. influenza pneumonia? Well, usually in babies and young children. You can also see it in adults with COPD and other chronic lung diseases. What about Klebsiella pneumonia? Think diabetics, alcoholics, and the elderly, basically immunocompromised people. Remember, of course, the red currant jelly sputum that you might read about. I would also throw in Moraxella catarrhalis, which you can see in the elderly and patients with COPD. Finally, it's worth mentioning a few specific bronchopneumonia types like aspiration pneumonia. Now, what types of bugs would you expect to find in aspiration pneumonia? Well, because it's aspiration, you'll probably see gram-positive or gram-negative anaerobes from the mouth. The pneumonia will also be located in the more dependent segments of the lung. Also, there's a ventilator-associated pneumonia, which is something we often see in intubated patients. Now, this is a bronchopneumonia frequently caused by staph, as I mentioned, and also Pseudomonas aeruginosa. See our microbiology section for more on these individual bugs. Now, when you have a patient with a non-productive cough, with fever and shortness of breath, you may want to think about an interstitial or atypical pneumonia, which is commonly caused by viruses, mycoplasma, Legionella, and chlamydia. Mycoplasma in particular tends to occur in what populations? Correct, older children and young adults. As you can see here on chest x-ray, you tend to see a diffuse, patchy inflammation localized to the interstitial areas at the alveolar walls. You often hear this pneumonia referred to as a walking pneumonia. Now, why is it called a walking pneumonia? That's because it tends to have a more indolent course than other types of pneumonia. Now, Legionella is a gram-negative rod that's associated with what? Aerosol from contaminated water sources, including cooling towers and large air conditioning systems. It causes, of course, Legionnaire's disease. Now, what is the milder flu-like form called? Well, that's called Pontiac fever. Legionnaires can be deadly if not treated with macrolide or quinolone. Here's a silver stain of some lung tissue in someone with fatal Legionnaire's disease. The dark specks are all Legionella pneumophilia bacteria. Chlamydophilia pneumonia is a common cause of community-acquired pneumonia. But what if I told you that a patient working at a pet store comes to you with signs of atypical pneumonia? Well, then you'd probably want to think of psittacosis caused by a Chlamydophila psittaci. Psittacosis is also known as parrot fever, secondary to transmission from pet birds like parrots or parakeets. Lung abscesses are a localized pus collection in the lung parenchyma. Lung abscesses are most often due to aspiration of GI anaerobes. You can also get it from bronchial obstruction, such as lung cancer. In general, these folks are sick, malnourished, older, or debilitated in some way. The typical bugs are anaerobes like Peptostreptococcus, Bacteroides, and Fusobacterium. They typically respond to clindamycin, which has excellent anaerobic coverage. Aerobic bacteria like Staph, Strep pyogens, and Klebsiella can also do this, especially in what setting? Well, that would be a hospitalized patient with aspiration pneumonia, and here you'd probably add a cephalosporin or ampicillin plus sulbactam. Finally, don't forget that fungi like Aspergillus and Candida can do this as well as parasites like Entamoeba histolytica. Now, what might you expect to see on a chest x-ray? That's right, an air fluid level.